Okay, sorry about that, everyone. So these are my disclosures, advance. And this is a patient scenario. So older woman, Elisa, yes, I'll tell you when to advance. An older woman, no prior heart disease, multiple risk factors, admitted with heart failure. She has a LV dysfunction, elevated RBSP, multivessel disease, and suitable for PCR cabbage. So advance. So how to treat this patient, and you can keep advancing through this slide. Should this patient have revascularization? Should this patient have a viability study? Should this patient be started on medical therapy? And you can keep going. So we'll now talk about the STICH 3 studies. Keep going. So CID is a very common cause of LV dysfunction. Keep going. Cabbage is the preferred modality. PCI is used very commonly. It's usually associated with less early adverse outcomes, but more research is required. Keep going. So the several sets of guidelines that are relevant. The 2018 European guidelines gave cabbage a class 1 recommendation, PCI a 2A recommendation for limited disease, and a 2A recommendation for triple vessel disease after a heart team discussion. Keep going. But in the 2021 European heart failure guidelines, cabbage no longer was a class 1 recommendation, and PCI became a 2B recommendation. Keep going. And you can keep flipping through the rest of the slide. So the 2021 recommendations for in this group, cabbage received a class 1 recommendation for an EF of less than 35%, 2A for an EF of 35 to 50%. There was no specific recommendation for PCI in this patient group, but potentially could be considered after a heart team discussion. Advance, please. And in the 2023 American Guidelines for Chronic Coronary Disease Management, cabbage remained a class 1 recommendation. Keep going. However, there is no modern, high-quality randomized evidence addressing which modality of revascularization is most important in this patient population. Keep going. So there is historical data and use of published individual patient data meta-analysis using the landmark trials from the 70s and 80s, and showed a benefit of survival advantage with cabbage for patients with an EF less than 50%. Very few had an EF less than 35. The relative benefit was similar for patients with normal versus reduced EF, although the absolute benefit was greater, and that was because the absolute risk was greater. However, caveats are the mean age very young. The mean age was 51, and medical therapy was quite limited at that time. So keep going. So STICH was a 1,200 patient, median follow-up of 50 months. The median age was older now, 59 years. EF was 28%, and 60% had triple vessel disease. Next slide. However, it was neutral. Primary outcome was all-cause mortality at 5 years, did not meet statistical significance. And the survival in the cabbage patients did not become better than the medical patients until after 2 years. In other words, there may have been a survival advantage, but it was deferred. Next slide. However, when the patients were followed up to 10 years, next slide, we did see a survival advantage with cabbage over medical therapy. This is in terms of all-cause mortality on the left, and other outcomes, including death or cardiovascular death. Keep going. There's one large trial comparing PCI with optimal medical therapy, Revive PCIS, 700 patient trial. The age was now 69 years, the mean EF 27%, but only 40% had triple vessel disease. Next slide, please. The primary outcome was all-cause mortality or heart failure hospitalization. It was not different. Advance, please. And all-cause mortality. Advance, please. All-cause mortality was similar in both and high in both. Now, they did report on viability recently, and the patients mostly had viability according to MRI studies and to a lesser degree to between stress echo. Overall, viability was not an important treatment effect modifier. In all patients, viability did not affect outcome. In the middle panel, non-viable myocardium was associated with outcome and inversely associated with an improvement in EF. But of all, scar was the most important factor, that it was associated with adverse outcome and inversely associated with improvement in EF. Advance. So some population data. This is from the Swedish registry. Advance. So in the left panel, cabbage in red was the predominant form of revascularization before 2010. PCI in blue became the dominant form after 2010. However, there was a large center-to-center variability, slide on the right, with some centers strongly using PCI in this patient population and other centers still using cabbage. Advance. This is a similar slide from Ontario, Canada, and all patients had LV dysfunction. Overall, there were more patients who had PCI, or the extent of CAD in these patients was much less. However, in the propensity match study of over 2,000 pairs, cabbage had a strong survival advantage. Advance. The single most extensive meta-analysis was a network meta-analysis by Godino and colleagues. And overall, you could advance. Overall, cabbage was the preferred therapy against medical therapy and preferred against, you can advance as well, and was preferred against PCI as well. You can advance, please. And cabbage bettered PCI, okay. That was a study including all data. Now, in a limited study restricted to patients following 2010, this has been presented as currently under review. Keep going. So there was a benefit in terms of all-cause mortality comparing cabbage and PCI. Keep going. And we use, when you create a KM curve from deconstructed KM curves, there was a benefit in terms of cabbage versus PCI over the long term in terms of mortality. Advance, please. And because of non-proportional hazards, we looked at restricted mean survival times. You can advance. And then in the column on the right, there was a progressive improvement in restricted mean survival time. Over 10 years, it became increasing over time. Advance, please. However, in terms of stroke, overall, there was less stroke in these patients after PCI versus cabbage. Advance. And when you look at the instantaneous risk advance, it was most significant very early after intervention, but became lower throughout the follow-up. You can advance again. However, not every patient is accepted for surgery. The Optimum study is a registry of patients who were declined for surgery. They were older. The mean EF was 42%. A lot of them had previous surgery, and they had other important risk factors. Advance, please. So these are the common reasons for not accepting a patient for surgery. The most common was poor distal target or conduit. The second most was severe LV dysfunction. Advance, please. They had very high, or very advanced coronary disease, and they had very advanced PCI procedures. Many had a left main PCI, many had a CTO procedure, and quarter had hemodynamic support. Advance, please. So these are the predicted surgical scores. They were more than 5%. The actual surgeon's predicted score was 10%. However, the observed mortality was 5%, very similar to the predicted scores. In other words, PCI is very valuable, or can be very valuable in this patient population. Advance, please. As far as the conduct of CABG, this is from the ATS consensus document. Advance, please. So the upper algorithm is for patients without high-risk features. Advance. The lower segment is for patients with these high-risk features. And the highest risk features include decompensated heart failure, very severe LV function, poor RV function, and valvular disease as well. There's a recent article in Artificial Organs describing the Cleveland Clinic use of the microaxial support in these patients, and I just include this for your interest. Keep going. So these are the guidelines from the expert consensus document, and I will say that off-pump surgery received a 2B. We will hear more about that, but it is recommended. It's only considered by surgeons with particular expertise in this patient. Keep going. As well, that it's reasonable to consider an LV lead in these patients and to consider either left atrial ablation or an atrial fibrillation selected patients. Keep going. So I think Sunil has left us, but he could hopefully have commented on this. But these are the main features of high-risk PCI. And I would contend that this is extremely important for people with LV dysfunction, because of very advanced coronary disease, as well as many of them have mechanical support, and by definition, they have LV dysfunction. Keep going. And just keep going throughout this slide. So these are the main features of advanced PCI, and I would say that these are important in general, but extremely important in patients with LV dysfunction because they have more advanced CAD and they have limited reserve. Keep going. Is mechanical support necessary? Well, that's debatable. This was a cohort study from MedStar in DC, 1,600 patients without planned mechanical support. Mortality in this group was 1.6%, and unplanned mechanical support only 1%. Advance. The PROTECT series of trials compared the Impella versus balloon pump in the first study and did not meet the primary outcome, but did meet a secondary outcome as seen in the slide on the right. Advance. PROTECT 3 was a cohort study, and when compared to the PROTECT 2 patients, did see further improvements. Advance. And we're now looking at PROTECT 4. Advance. And this is a study comparing Impella-supported PCI in high-risk patients with LV dysfunction and multiple coronary risk factors versus no planned mechanical support. Advance, please. Which brings us to STICH, which is a group of studies comparing PCI and CABG in this patient population. Advance. So we think there is clinical equipoise. Main thing is that there's no real good, compelling, robust data in this patient population. Advance, please. So I'll talk to you about the Canadian study. It is funded by CHR, which is our national funding agency. Keep going. There is a study design manuscript for those who want to read more about it. Advance. So this is the overall study design. It's an international multi-center trial in 750 patients, comparing CABG and PCI in patients with prognostically important CAD and reduced LV function. Advance, please. So the primary aim is to determine whether MACE or heart failure readmission is reduced in patients with CABG compared to PCI in this patient population over a median of 5 years. Advance, please. So these are the inclusion criteria. One of the main things is that the patients have to be amenable to both PCI or CABG, and that revascularization is appropriate in these patients. Advance. Key exclusion criteria are the following. They cannot have decompensated heart failure at the time. And if they do require, or there's a planned other major concomitant heart operation, they would be excluded. Advance, please. So the collaborative is to perform harmonized RCTs comparing PCI and CABG in this patient population, and to obtain funding for each of these studies separately, and to merge individual patient data in the end to test the mortality hypothesis. STICH 3C, primary outcome is MACE or heart failure readmission. Advance. So the primary outcome is superiority of CABG versus PCI in terms of mortality. The primary endpoint is all-cause mortality for the collaborative. Advance. And so far, there has been funding for the Danish, Swedish, Canadian, and UK applications, and they're all testing the same question, the same population. The recruitment has started in Sweden, Denmark, and Canada. Advance, please. And this is sort of a graphic showing the different trials, the Canadian trials on the left, the other potential trials on the right, and they merge in the end to test for mortality in this patient population. Advance, please. So how do we treat this patient? Just advance through this. So Gail thinks that this patient looks like a candidate for STICH. Bob will speak to their attending to see if the research coordinator can screen the patient and advance. In the meantime, they'll be started on low-dose heart failure medication, but refrain from getting a viability study at this stage. Advance. So these are our conclusions. And we think a large RCT in this patient population is desperately required to close the evidence gap. Thank you.